Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have here a patient who has bilateral fully occluding earwax, and it was this their left ear that they reported their main symptoms being inside. Their symptoms included otalgia. So otalgia is the medical name given for earache. They were also experiencing tinnitus. So for anyone who doesn't know what tinnitus is, it's typically a ringing or a buzzing noise, but it could actually be any noise that originates either with inside your ears or with inside your head. So it's not an external sound. And the patient was also, of course, experiencing reduced hearing. They weren't able to hear their friends and family, which much to their annoyance, but the patient advised that in some ways they felt blessed that they weren't always hearing their friends and family, because they had an excuse, for example, when it was there around at the pub, not to get it in because they couldn't hear. So the patient does have to attend every year or so. So it is a chronic problem they have. And I would say if you fall within the waxy category, inverted commas, so about 10% of the population, give or take, will need to have wax removed on a, I wouldn't say frequent basis, but more than once in their lifetime. So they are prone to having a wax impaction problem. We call wax impaction ceruminosis, actually. That's the medical term given for it. On average, if you are one of those people that will have to have earwax removed throughout their lifetime, the average, I would say, is between, say, 18 months, 2 years, maybe a bit more frequent even. And then you get some extreme cases. I got some clients that have to attend every 3 or 4 months, others 6, 7 years. So it does vary a lot. Now, with this consistency of the wax, it's very soft, mushy. They did try and remove it themselves. You may have seen right at the beginning, they know better. They know they shouldn't. And there was an indentation into the core. You probably just see it there to the right. It's not as visible now. So the patient did try and remove it, and I keep explaining that if you try and remove it yourself, you're just going to impact it further in. And this is what's happened. They've really impacted it against their eardrum. And it is this soft, sticky consistency. And I'm just trying to work it off the canal walls. And I'm just going to wriggle it left to right. You can see the wax is lodged. There's a narrowing. There's a V shape of the ear canal there at the bottom. And that valley, that region of the ear canal is called the isthmus. That's when we get a narrowing of the ear canal. And the ear canal after the isthmus, it widens again. So if you push wax beyond the isthmus and the wax expands, that wax plug is bigger than the isthmus. So it's a matter of then extracting it, wriggling it through, define physics almost to get it through a smaller aperture. Now, fortunately, earwax is a bit soft. Generally, you can get really hard earwax, which is very hard to bring through. Now, the ear canal itself is bony, so that's not going to expand. If this is on the cartilage portion of the ear canal, then we could bring it through. Now, that's the patient's eardrum. It does look retracted. I don't know if you've had that, if you could see that as well, especially in the back part and the centre part. The eardrum looks like it's pulled in. The hammer bone, the malleus bone, is almost horizontal, which is normally a sign of the eardrum being retracted, but this patient's eardrum just looks like this. We always perform pressure test, tympanometry, and it comes back normal, but it does really look retracted, and sometimes the eardrum has just had this appearance, and it may well be that the eardrum it's just that's the way it is for this patient. It's pulled inwards, but the pressure behind the eardrum is equal. The air pressure is equal behind the eardrum in comparison to the atmosphere in the ear canal. So when the air pressure is equal either side of the eardrum, that's when you hear optimally. That's when the eardrum vibrates the most. And so this patient doesn't need any onwards referral. It's just their eardrum. It's just congenital. This is the way it looks for them. However, because it had that retracted appearance, you'll see at the top there's some soft wax there. Now, I normally wouldn't remove that because it is literally staining almost. But in this case, I just wanted to make sure there's no retraction pocket at the top of the eardrum, the attic region or the posterior superior quadrant. So you'll see it in a moment, me removing it. So I just want to see what's behind that. I've had instances in the past where I removed some innocuous looking piece of wax, and behind that there was infection, cholesteatoma more specifically. So you can see I'm just approaching this. I've got to be really careful because we are right next to the hammer bone, the short process. That bulb was that round sphere just southeast of the suction probe. That's the bone of the hammer bone. That's the top part. And I just removed enough just to reveal that there's no retraction pocket, there's no skin ingressing. There's a bit of soft wax around the periphery and the medial part of the ear canal near the eardrum. That's fine, that's staining. I tried hovering over it to see if it comes away, but it was stuck, it was wet. We don't want to try and remove that, guys, because to do that, it's not going to help the patient. And in fact, we might well graze the ear canal, cause an infection, and we're making matters worse. So you've got to know when to quick wash your head sometimes. Now, if there's a bit of wax on the side and I hover over and there's no risk, I will try and remove it. But the purpose of earwax removal is not to remove every little aspect of wax. A bit of wax is good for you. I've got wax in my ear. In fact, I'll try and take a photo tomorrow or later on in the week, and I'll upload it on one of the videos. I'll put it as a still, and you'll see that I've got a bit of wax, and a bit of wax is good for you. Earwax is acidic. That's because the oils and sweats that are secreted within the ear that are two of the core ingredients of earwax alongside dead skin cells. They are oily by nature, and the oil, the acidity in the oil and the fatty acids, they help to inhibit harmful bacterial and fungal growth. Wax is also oily, so it's greasy. It helps to lubricate the skin, so it prevents water that may enter the ear being absorbed by the skin cells, because it provides this hydrophobic layer of veneer, and it also helps the skin cells retain its own natural moisture. Otherwise, without the oily veneer, fluid within the skin cells will rise to the or actually in between the skin cells as well. It'll rise to the surface and it'll evaporate. So oil helps to retain internal moisture and repels external moisture. And finally, earwax is sticky, so any foreign particles, dust, will stick to the wax if they enter the ear. And for the majority of the population, earwax comes out naturally. It's a conveyor belt. The skin that lines the ear canal, as it dies, as it sheds, it just moves sideways out of the ear, exactly like a conveyor belt. Same constant cycle, and wax sitting on the surface of the skin cells will also be transported out of the ear. Oops, I forgot to edit this bit. I just came out and I just wiped the lens. The suction tube was blocked as well, so I was just unblocking it. We can see in the distance, you can peek through the wax on the top right. Just see the eardrum there. And again, I'm just trying to manipulate this out of the ear. It's quite sticky, so with this type of wax, because it's soft, mushy, sticky, you just got to kiss the surface. You apply too much pressure, you'll just indent into the wax, potentially push it further in, and you'll just block the suction probe continuously. So you just want to kiss the surface. That's the back part of the ear canal. We're just going inferiorly now. This is the floor of the ear canal, and so this side's coming away much easier than the left side. The eardrum's fully visible already, so you can see the difference in the appearance of this eardrum and the other one. The other one just has that appearance that it is sucked in. I suspect the eardrum is pulled in. It is sucked in. But sometimes when the eardrum's sucked in, the inner membrane is a mucosal membrane, so it's a bit sticky. And I spoke to a colleague of mine who's an ENT surgeon, and I just asked if it's possible if the eardrum is sucked, just say they had negative middle ear pressure, a patient, which causes the eardrum to buckle inwards, because when the air pressure behind the eardrum is less, should I say, than the air pressure in the atmosphere, that's negative middle ear pressure, and that can cause the eardrum to get sucked in. It's like a vacuum effect. And the inner membrane of the eardrum is made up of the same skin that lines the middle ear, and it's a mucosal membrane, and that is quite sticky. So is the epidermis layer, so even this external part of the eardrum. So the eardrum is made up of 3 membranes. The mucosal membrane lines the inner part of the eardrum. The outer membrane is the skin that lines the ear canals. It's an epidermis layer. And the middle layer is a fibrous tissue layer. And so both sides are quite sticky. So it is possible for the eardrum to get sucked in and then stick to one of the bones. And even though the air pressure then manages to equalize itself, the eardrum stays in that position. So when you do a pressure test, it comes back normal. The eardrum is vibrating okay, so under those circumstances, you're just going to make sure there's no skin ingressing in the attic region, like I checked by removing that bit of staining of wax, just to see what's behind that, and that was fine. But this eardrum looks more orthodox, it's more a typical eardrum, Again, I'm just trying to peel some sticky wax, dead skin around the edge. It's not going to massively make a difference, but if I can hover over it, it can come away brilliant. If not, as soon as I feel there's an element of risk involved, we just come away. But this is coming away fine. Patient's really still. I'm just back peeling the skin here, trying to reverse it out. Let's see, if we graze that canal here, we can potentially cause an infection. That's why I went over. I could sense it wasn't going to suction, so I came away. Just going to mop up some of this oil and wax near the entrance. I am going to go back in. There's a bit of wax on the anterior canal wall. I think I'm going to remove that because there we can see. So I've got the fine end angled. And can you see that skin in the background? It's getting attracted to the vacuum and it's flapping. So that skin, that's the reason why we stopped there, was it was clarinetting. As I was removing that, it was vibrating. When it vibrates, when it's attached to the sucker, so at the moment it won't, but when it's attached to the sucker and it vibrates, it emits a very loud, high-frequency squeal, which is really deafening. So that's why we kind of just came away from that part. And that will just naturally shed. It's half peeled away, so it should just fall and naturally migrate out of the ear. I'm just going to re-enter and you'll see the patient's eardrum. It's really healthy. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.